It's great to see you again. Welcome to our final keynote speaker. It is my great honor to introduce Dr. Brian Smedley. Dr. Smedley is a national thought leader in the field of health equity and a true powerhouse. His achievements are both awe-inspiring and humbling, and I cannot think of anyone who better embodies SPSSI's mission or commitment to science, policy, and social justice. Dr. Smedley received his PhD in clinical psychology from UCLA and an AB in psychology and social relations from Harvard University. As a giant fan of Dr. Smedley and his work, I've long admired how he continually seeks out new ways to amplify the impact of research on policy to reduce systemic disparities and advance health equity. It's impossible to fully represent Dr. Smedley's groundbreaking work, but I hope this brief snapshot will give you a sense of his many contributions. Currently, Dr. Smedley is a senior fellow in the Health Policy Division of the Urban Institute, where he conducts research and policy analysis to address structural and institutional forms of racism affecting the health and well-being of people of color. Over the course of his distinguished career, Dr. Smedley has held numerous positions that reflect his deep commitment to health equity and social justice. Prior to joining the Urban Institute, Dr. Smedley was Chief of Psychology in the Public Interest at the American Psychological Association. He led APA's efforts to apply the science and practice of psychology to fundamental issues of human welfare and social justice. Dr. Smedley was the co-founder and executive director of the National Collaborative for Health Equity, co-directed the Robert Wood Johnson Foundation's Culture of Health Leadership National Program Center, and was vice president and director of the Health Policy Institute of the Joint Center for Political and Economic Studies in Washington, D.C. That's a research and policy organization focused on addressing the needs of communities of color. Additionally, there's more. Additionally, Dr. Smedley co-founded the Opportunity Agenda, a communications research and policy organization which is working to build the national will to expand opportunity for all. And as a senior program officer at the Institute of Medicine, he served as study director for the seminal report, Unequal Treatment, Confronting Racial and Ethnic Disparities in Healthcare, among numerous other reports on diversity in health professions and minority health policy research. Dr. Smedley has received numerous awards, no surprise here, that honor him for his impactful, far-reaching contributions, including the American Public Health Association's Cornely Award for Social Activism, the Congressional Black Caucus Congressional Leadership and Advocacy Award, an APA Presidential Citation, a Health Trailblazer Award from the Rainbow Push Coalition, and a Congressional Black Caucus Health Care Hero Award. Always generous with his time and expertise, Dr. Smedley is the treasurer and a member of the board for Poverty and Race Research Action Council, the chair of the advisory committee to the Maryland Office of Minority Health and Health Disparities, and a member of and consultant to the Institute for Healing, Justice, and Equity at St. Louis University. Dr. Smedley has also shared his time and expertise with SPSSI over the years as a council member and in many other capacities. I was fortunate to serve on SPSSI Council with Dr. Smedley, but we first met a long time ago at a SPSSI conference, and this is really what I want to speak to, what isn't visible in Dr. Smedley's impressive body of published and public work. Dr. Smedley isn't only about changing systems, he changes lives. It isn't just what he does, but how he does it. I don't remember the year, or maybe I don't want to, but I think we were at the University of Michigan. It was my very first SPSSI conference, and I had just completed my first year as an assistant professor. Dr. Smedley, a former APA Congressional Fellow, was APA's Director of Public Interest Policy, and he gave a talk about getting involved in policy and being an APA Congressional Fellow. It was beyond thrilling. I don't even have words for it. After all these years, it was beyond thrilling to hear Dr. Smedley talk about a career pathway that seamlessly integrated research, policy, and advocacy. And I immediately knew that this is what I wanted to do. At the time, I was very shy, and I pushed myself to stand in a very long line to talk with him. I nervously waited, and I still remember his kindness, his encouragement, and his sage advice. Dr. Smedley's vision, skillful use of research to inform policy, and belief in transformative change changed my entire career trajectory. And I know this is the case for many SPSSI members. I just heard some stories like this out in the lobby, and countless others as well. Brian, I speak on behalf of all of SPSSI in thanking you for your remarkable work and unwavering dedication to justice and a true psychology in the public interest. Please join me in welcoming Dr. Smedley.
It's so nice. You make me cry. Oh, thank you.
There has to be a picture for everything. Oh, everything. Thank you, Brian.
Oops.
Oh, that's great. Great.
Thank you. Well, good afternoon. That was just the kindest, nicest introduction, Heather. I have to take a moment. Thank you. Thank you so much. SPSSI is one of those places where you can imagine and dream what you can do with your training as a psychologist to make a difference in the world. That's how I've often looked at SPSSI, which is why being at this conference is always like coming home. We all get it. We've been trained and blessed to do what we do. I certainly feel blessed to have had 30-plus years of work to try to advance health equity. Sometimes it doesn't feel like such a blessing these days, but nonetheless, we are so fortunate to be here in this moment. So I want to thank SPSSI, Heather, Anila. Thank you for inviting me back to this wonderful family. I want to start with a word of support for those who are affected by federal actions, the madness going on in Washington, including those of you who've been affected by the cutting off of research grants. Many folk in this room, but you're still here. I want to stand in solidarity with those who have been threatened. International students threatened to not be able to return to school. Threats to religious minorities. Threats to LGBTQ people. Ongoing assaults on people of color. It's been hitting the fan lately, hasn't it? So this is really a moment of standing in solidarity in powerful ways. I can't imagine a better place to be in this moment than in a room full of folks who are committed to using our skills, using our discipline to make a difference. We're all diminished by the resurgence of overt bigotry and bigotry driving public policy. That's one of the things that is fundamental for us. Science should drive policy, not broken ideologies that divide us. So we're here to resist. And I think there's no better way to constructively and healthfully resist than to come together in spaces like this one. SPSSI's been creating spaces like this for 85 years. And in that time, SPSSI members have seen dramatic progress toward social change. We've also seen stagnation and in many cases regression. But that's part of our political process. That's the cycle of our political forces. We are here nourishing each other, building strategies to withstand these current regressive forces, and we're plotting a better path forward. That's what I really want to emphasize this afternoon. There is a path forward, and it is our job to offer that vision. That's part of our resistance working. I'm encouraged because there's been good news in recent days. There's a federal court that has put a stop to some of the cuts in NIH funding that really doomed a lot of existing research. I know other grants are still imperiled, but the fact that a court ordered the reinstatement of some grants, determining that these cuts were arbitrary, is critically important. Scholars are pushing back against ideologically driven barriers to inquiry. We should have no barriers to inquiry to pursue truth. In my own area of work, research to advance health equity is clearly in danger. Prior to this year, our field arguably had been making slow and steady progress toward identifying the root causes of health inequities. We've been building power and knowledge through strong partnerships with affected communities. But in a matter of months, this year, this progress has been deeply threatened. As I'll discuss in my presentation, that the federal health infrastructure, particularly the health research infrastructure, is being dismantled, particularly research focused on advancing equity. Research on diversity, equity, and inclusion will not be funded, as if these were not legitimate areas of scientific inquiry and intervention to save lives. Research and training programs that have prioritized the needs of historically marginalized populations, balancing decades of historical neglect, are being shuttered. And to make things even worse, some of these folks in Washington want to shut off federal data collection efforts. These are, of course, the very tools that help us to document and understand barriers to good health that people of color and other marginalized populations face. According to this ideology, if there are no data to document the problem, it doesn't exist. One can't escape the conclusion that this is the strategy. This reminds me of something that happened roughly 20 years ago that I have some firsthand experience with. An earlier effort to suppress science and to look away from racial injustice. Same thing that we see happening now. As Heather mentioned, I had the honor of working at the then Institute of Medicine, it's now called the National Academy of Medicine, and I worked on a research project that resulted in a report, Unequal Treatment, that Heather mentioned. This report had a major impact on the healthcare industry. It showed how people of color can be marginalized even in systems that most Americans wouldn't expect to see racial discrimination in those systems, particularly health care. The report was unimpeachable, prepared by an all-star committee. It included luminaries like Dr. David Williams, Dr. Risa Levizo-Murray, and our own Dr. John DeVideo, who was enormously influential in bringing the science of implicit bias to the committee. The report made front-page news in the New York Times and Washington Post. I thought we were making some progress. Shortly after it was released, Congress acted to require the Agency for Healthcare Research and Quality, AHRQ, to release every year a report on the status of efforts to reduce racial and ethnic healthcare disparities. The first draft of this report was leaked to the media in a process that literally involved trench coats, plain manila envelopes, and obscure parking lots in DC. Very similar to what you see in movies about Watergate, things like that, but it actually happened. And I thank God it did, because that draft stated that racial and ethnic healthcare disparities are merely differences in care quality and outcomes that don't necessarily reflect bias or injustice. In this view, patients are as much or more to blame for their poor outcomes as the health professionals and health systems that serve them. This, of course, runs against the science, which we so meticulously compiled in the Unequal Treatment Report. The report found that patients of color receive a lower quality of care on average than white patients across a range of disease areas and clinical services. These inequities occur even when we control for differences in economic factors like health insurance status or the ability to pay out-of-pocket for out-of-pocket costs. The report stated that many complex factors contribute to these disparities, including implicit biases on the part of health professionals, as well as structural factors such as persistent healthcare segregation and inequitable healthcare financing. But the report noted, these factors are amenable to intervention. We don't need to, and indeed should not passively accept inequity in healthcare. This conclusion was clearly not in alignment with the then political appointees at the Agency for Healthcare Research and Quality, who edited the draft prepared by AHRQ's scientists to suggest that disparities are just differences and we don't really need to worry about it. When this edited draft was leaked to the media, think trench coats and obscure parking lots, a story appeared in the front page of the Washington Post. Federal scientific document altered to minimize healthcare disparities. The George W. Bush administration was forced to backtrack and release the original document as prepared by AHRQ's scientists. And in the 20 years since, AHRQ's annual healthcare disparities report has been rigorously tracking racial and ethnic health disparities in healthcare access, quality, and outcomes as required by Congress. I hope, but I'm not optimistic, that this report will maintain its rigor going forward. I tell this story not to minimize what we're going through now. The assault on racial justice and equity-focused research that's happening now is much worse than it was 20 years ago. But it serves to remind us that the truth can't be suppressed for very long. We've been here before, and we've persevered. 20 years ago, things looked bleak from a racial and health justice perspective. But just 15 years ago, dramatic, but even if imperfect, health reform legislation passed Congress and was signed into law by President Barack Obama. You'll recall that this same legislation, the Affordable Care Act, also elevated what was then the National Center for Minority Health at NIH to the National Institute on Minority Health and Health Disparities, thereby increasing its capacity to support health equity research. The knowledge and the infrastructure built from these investments will not go away simply because they're out of favor with the current administration. We have to continue to nourish our field and prepare for the day when we can truly practice liberatory and justice-focused work. And that day will come. My work focuses on trying to understand the role of racism in Black health, particularly institutional and structural forms of racism. So I won't be receiving any more federal grants anytime soon. I'm okay with that. But I'm confident that our field will survive and flourish in the future. To do so, I think there are several things that we must do and several things that we cannot allow to happen. We must continue to gather in spaces like this to plan, to regenerate, to replenish ourselves, and to be prepared to move forward. We must not allow our science to be co-opted. There's a new generation of pseudoscientific race science that's being funded and published by far-right outlets. We can't allow legitimate journals to be co-opted or pressured to publish alternative viewpoints as if they were equally valid as the scientific work that we have been putting out in this field for decades. This modern pseudoscience, of course, has been debunked for decades, but those that believe deeply in the belief in human hierarchy want to preserve this line of pseudoscience. We also need to be clear about language. We've all seen some folks co-opt letters. First there was the boogeyman of CRT. Now there's the boogeyman of DEI. And so we've got to be clear about what this language means. Let's not let people steal our language and particularly fill in for amorphous concepts with their own sense of what these concepts are. In my view, if you're against equity, if you're against diversity, if you're against inclusion, you are for discrimination. You are for segregation, and you are for exclusion. Not only are these immoral, they remain illegal. So let's be clear about what we stand for and not allow our viewpoints to be co-opted. We need a new vision for health in the United States that's built on fundamentally different principles. Our current healthcare systems were not created to produce health, and they certainly were not created with Black and Indigenous people in mind. That may seem shocking to some. Our healthcare systems were not intended to produce health? No, they were intended to produce profits. Other countries get that concept, that equity and profit are not compatible. We need a vision that draws upon sources of health knowledge from around the globe, and particularly indigenous traditions. And we need to start planting the seed now to create new systems out of the ashes of current approaches. That's why I'm really honored to co-chair a commission on anti-racism in solidarity with my friends, leaders in this field, Drs. Aletha Maybank and Dr. Zinzi Bailey. I want to give you a preview of what we're working on to build a health research workforce focused on equity and community, drawing on decolonial and anti-racist principles. All right, this slide I think is self-explanatory. We're in a moment of crisis. It's a lot of danger, but there's also opportunity. Here is where I remain optimistic and hopeful. I believe deeply that there is opportunity even in this destructive time. So much is happening that's destructive. U.S. healthcare and public health are in a state of crisis. We face unsustainable costs. Our resources are inequitably distributed relative to community need, and public anger at health insurance companies and public health and government is growing. We saw that during COVID. U.S. medical and health research infrastructure is being shaken to the core by the cancellation of many federal grants. Many millions of Americans are likely to suffer losses of health insurance coverage. Increases in chronic and infectious diseases. We're going to be a sicker and less healthy population, and we will be worse off for it. As horrifying as this picture is, these developments are likely to fuel broader calls and political support for reform. There are many manifestations of colonial and white supremacist ideologies embedded in our healthcare and public health systems. We have to take a step back and look at historically how these ideas have come to fruition. These include beliefs such as the belief in human hierarchy as natural, and some on the right use this ideology as a potential justification for the poor health of racially minoritized groups. In other words, it's biological, it's natural that they have poor health. Other beliefs, rigid adherence to market fundamentalism regarding healthcare services. In this country, we don't view healthcare as a right, but rather a privilege to be enjoyed by those who have the resources to afford it. Beliefs that only individual merit can determine access to health professions' careers, not what the community needs or what society needs. Historically, our public health systems have been de-emphasized and devalued relative to individual responsibility. We don't understand the need for collective action to protect ourselves and to preserve our health. We believe that it's your job and your job alone. And we also believe that knowledge production and transmission should reject traditional and indigenous sources of knowledge in favor of European approaches. We've been narrow in our exclusive view in looking at Western approaches to knowledge production. I've often been inspired by the work of Kamara Jones. I know many of you are as well. I often turn to her 2020 paper, Seeing the Water, 7 Values Targets for Anti-Racist Action. This nicely encapsulates some of the ideology left over from settler colonial principles and worldviews, and from the belief in human hierarchy. Kamara argues that there are 7 action targets, values that we need to begin to address. One is the narrow focus on the individual here in the U.S. You're all familiar with that. We stand alone among many nations in our emphasis on individual agency, which obscures our need for collective action. We often have an ahistorical stance in this country. We don't turn to history. We don't learn from history, and we're, of course, doomed to repeat it. But there are also, of course, active efforts to deny our history and to obscure our history, particularly the contributions of people of color to this country. We believe in the myth of meritocracy, that individual success should determine who gets the spoils. We believe in a zero-sum game, that there is a finite pie of resources, and that if people of color were to get some of those resources, that would mean white people would get less. We, of course, know that that's not true. None of these myths are true. We also have a limited future orientation. We tend to look only in the near term. We don't think, as many indigenous cultures do, about thinking 7 generations ahead, so that we're reflecting on the decisions that we make as a society and how that will impact future generations. We believe in the myth of American exceptionalism. We can't learn from anybody else. We're distinct. We stand out among others. Well, we do stand out, but not in the right ways, right? Our healthcare systems are incredibly expensive, inefficient. We, all of you know, we're spending over $3 trillion a year on healthcare, far more per capita than any other Western nation. And we stand alone among Western nations in our stubborn reliance on market-based healthcare systems. And then finally, the through line running through all of this is the belief in white supremacy, the belief in human hierarchy that's so deeply embedded in our consciousness that it is hard to see a world that has a different reality. Kamara also talks about structural targets for anti-racism action, tackling things like residential segregation on the basis of race, tackling the inequitable funding of public schools based on local property taxes, and all of you know what the consequences of such policies are. People in poor cities, poor neighborhoods have lower resourced schools. Over-policing of communities of color, disproportionate incarceration of black and brown people, communities of color as environmental sacrifice zones. These are the structural issues, but unless we address those values that Kamara was talking about, individual determinism, market fundamentalism, unless we address those value systems, it becomes hard to address the structures and systems that help to perpetuate racial inequality. Our current approaches to knowledge production, unfortunately, reinforce many of these ideologies. Even today, much of the research and research infrastructure for equity continues to benefit researchers and research institutions rather than communities and populations that need the most help. Ongoing publishing of racial essentialist research, suggesting genetic or biological factors that are behind racial and ethnic health inequities. This kind of research persists, and it even happens in what I'll say are innocent ways, to the extent that researchers use race as a variable but then don't explain their conception of the term race and how it is a social construct, leaves open the notion that any differences that are found in research are due to fundamental or biological causes. This is why history is so important to bring into our research. Every one of us can benefit from having an historian's viewpoint that helps to incorporate how we got here and the ideologies that result in the policies and structures that we have today. We continue to suffer from underrepresentation of scholars from communities of color, women, others who could contribute so much to our understanding of the experiences of these populations. And as a result, we have a lack of diversity among our academic medical journal editors. So our publishing processes, in many ways, inadvertently reify notions of biological race. A lot of folks are trying to tackle this problem. My former employer, the National Academy of Medicine, recently released a report. This was prior to the election, but I think it still holds today. Their report, called The State of U.S. Biomedical and Health Research Enterprise, Strategies for Achieving a Healthier America, I think is still relevant, even though it was released just last year prior to the election. In this report, the National Academies calls for several changes. One, they note that structural issues currently stand in the way of the research enterprise's efficiency and effectiveness. We have a lagging workforce, for example. Publicly supported research is not financially competitive with private sector research. Women and scholars of color are still an unacceptably small portion of the workforce. And increasingly large contributions from industry, venture capital, and philanthropy bring conflicting agendas that can result in research focused on what is profitable rather than what is beneficial for most Americans. This is a trend that is incredibly worrisome, particularly private equity investments in our healthcare systems that are designed to generate profits, not health. Other problems that this report points out. There's piecemeal funding driven by a variety of often conflicting agendas. This makes it difficult to cobble together the capital to comprehensively address the issues that are most directly impacting Americans. Think about institutional and structural forms of racism. What private equity funder is going to fund that research? Now that government is not doing it, we're relying increasingly on private philanthropy to help fill that void. What this report calls for is a national biomedical research funding collaborative guided by determinations of how to best organize and allocate shared investments from government, private sector, and philanthropy. This collaborative could be empowered to analyze best practices, create a large-scale funding model to address a national strategic vision, and to encourage pooled strategic gifts, philanthropic collectives that can make a large impact. These kinds of strategies can make a huge difference at a time when there is a federal retreat from investments in research, whether it's from NIH or CDC. We need to be able to find resources from those entities that get it, that this research has been in the benefit of the entire society and therefore should be prioritized because it yields a return on investment for society. This report also calls for prioritizing research that informs solutions for health equity. These include addressing long-standing challenges like increasing trust in medicine, science, and the biomedical research enterprise. Public trust in these institutions is at an all-time low, but yet this has been the engine that has kept America healthy and that has driven innovation in ways that make today a remarkable time for people, particularly if you're dealing with a chronic illness. We need to mitigate structural and systemic discrimination, deliver care to patients in communities where they live, and improve the communication of science and medical information so that we're not turning to crackpot science, so that people once again have faith in scientists and the best science that we're producing. And finally, we need to bolster community engagement and effective bidirectional dialogue. It's this community engagement piece that I think is going to make the biggest difference going forward with new models, new approaches to doing research that will upset the status quo. So, what are some attributes of community and equity-centered approaches to health research workforce training? This is the work of our Commission on Anti-Racism and Solidarity, and here are some of the recommendations that we're starting to generate. First, we believe that health professions education systems, medical schools, nursing schools, dental schools, schools of professional psychology should be accountable to the communities they serve through community governance and oversight. This is going to be an important new direction moving forward to decentralize resources and control over health and public health. We need health professionals who are trained to work in an interdisciplinary and a community engaged manner. This should be respectful of and aligned with indigenous and traditional practices and free from stated or implied hierarchies among health professionals. And we need a health research workforce that is trained, supported, and empowered to optimize population health, well-being, and equity, supporting prevention and well-being in balance with sick care. And of course, today, our approach is imbalanced with heavy investments in sick care and little investment in prevention. It's still true today that for every federal dollar spent on health, only about 5 cents are spent on prevention. We need to balance that equation. How would anti-racist and decolonial structures and systems inform health research? Well, as I mentioned earlier, there's a critically important role for community that our field has been beginning to embrace prior to the disruption that we're experiencing now. We need to increase community members' input over research funding, research questions, research methods, the interpretation of research findings, and research dissemination. This is a fundamentally different model, right? Where researchers used to be in control of all this. We decided the questions. We decided where the funding was going. We decided how to interpret those findings. And that approach, unfortunately, has left the field behind. We will build power and build our knowledge in full partnership with the communities whose health we're trying to improve. We need to increase investigator accountability to community partners for research outcomes. You all know that in many cases, we researchers have been guilty of partnering with communities, collecting data, publishing our findings, but we don't communicate that back to the communities that we've been working with. We need to be thinking about using that knowledge as a source of power and helping to leverage the community's own power to create a vision for health and equity. And we need to engage community partners in training future health research workforce regarding community-engaged practices. This has been the mantra in the health equity space in recent years. Community-engaged practices as being the gold standard for how we conduct our research. And that is the perspective that we need to embrace when we emerge out of this difficult period. I do believe that Americans will come around. I think that the damage that we're going to see over the next few years will compel a new political movement, and we're starting to see it happen, right? I'm reminded that Americans' attitudes about the federal government's responsibility regarding health care coverage has fluctuated significantly in recent years. This slide shows data from the Gallup poll where Americans are asked, do you believe that the federal government has a responsibility to ensure that all have health care coverage? If you look back at 2000, that was easily the predominant viewpoint in this country, that the federal government needed to step in some way to ensure that we can expand health insurance coverage to more Americans. That the share of folk opposed to those views was substantial, but of course, immediately during the congressional debates around what became the Affordable Care Act, we began to see those sentiments shift. We began to see a larger share of Americans opposed to the federal government's engagement role in providing health insurance. But in recent years, we're seeing an uptick again. We're seeing growing momentum and a growing sentiment in the public that our healthcare systems have not served us in ways that take care of Americans. So it is inevitable that this cycle will shift back. Everything in politics is cyclical, and I believe we are on the verge of a new progressive movement where we can offer a new radical progressive vision that can build on the public sentiment that these current systems have failed us miserably. This is where I think we each have an important role in ensuring that we're communicating about our science, ensuring that we're partnering effectively with the communities that we're seeking to whose health we're seeking to improve, and we can't let people co-opt our science. We have to stand firm around the principles that undergird our science, standing firm around the value of diversity, equity, and inclusion, and drawing sharp contrasts with those who oppose those values. I think we are close to getting to a point where we can reemerge from the ashes of what is being created currently. I often hear folk in progressive health circles talk about the need to dismantle our current systems, our current healthcare and public health systems, they serve few people well, right? And they certainly were not created to address the needs of marginalized populations. And in fact, they've done more, in many cases, to oppress these populations than to serve them. So it becomes critically important that we look to turn this dialogue around, that we build new narratives. We've got to emerge out of this narrow viewpoint, this narrow way of thinking about the world, where we're constrained because we believe there are no other ways to approach health and public health in this country. But there is a better way. And when we offer that vision, we can begin to see people coalesce and stand in solidarity together in ways that create a powerful social movement that will, I believe, bring us through to a new era when these opportunities are more apparent. So I refuse to be discouraged. I think it's critically important that we remain hopeful, remain optimistic, stay the course. It's difficult now because so much of that rug has been pulled out from under us, that rug, that infrastructure of support for our science, for our research. We've got to find creative ways to continue to nourish the field, keep the work going, because it will not be long before we're back moving forward with new paradigms to advance health and equity. I'm so grateful for a chance to be with you today. It's been encouraging to see our work and our enthusiasm not be diminished by what's happening. And I want to leave you with a quote from Dr. Paul Farmer, who, of course, was an incredible champion of human rights, civil rights, the late, great Dr. Paul Farmer. He wrote that the idea that some lives matter less is the root of all that is wrong with the world. And when you think about it, really, that's the fundamental notion that creates fractures within our healthcare and public health systems. The notion that we human beings can be ordered in some kind of hierarchy, and that some lives are more valuable than others. You can hear echoes of Kamara Jones in what Dr. Farmer is writing here as well. So if we understand that we can challenge that narrative, that we can move forward in a way that helps to create health and justice for all, I do believe that we will find a broader movement of people that want to stand with us in solidarity to create new systems. I thank you so much for your time, for listening. Let's come together and bring forward a new vision so that we can advance this work and advance justice for all. Thank you so much. So I wanted to thank you. I wanted to leave a little time for questions, but I know, Heather, you're going to wrap up as well.
Well,
So
there's time for questions.
okay.
Absolutely.
Yeah, thank you first off for bringing public health into this sphere. I think that's so important. As someone who just graduated with a Master in Public Health, it's so nice to see. But you said we should talk about how we got here, which I really appreciate. Like, how did policies lead to structural and systemic issues that we're currently trying to solve and fix, really? But how do we do this while still getting funding and publishing? Because I can see a lot of people revolting against the idea that we caused these issues, even though we know we did.
Right. Yeah, thank you for that question. The notion that somehow our research is causing a problem because it's uplifting an inequity, that's the very thing, that's the crux of it, right? There are forces that don't want inequities exposed. So your question is absolutely important. How do we continue to work and to really work upstream and to talk about fundamental causes, structural racism, institutional forms of racism? I was making a joke earlier when I said, I study that, so I'm not going to get federal grants. But thankfully, there are some funders that are standing in the breach. They get it, that just because the federal government has used ideology to suppress this science, we need to find other resources to ensure that the work can continue. I want to call out the Robert Wood Johnson Foundation in particular. Their president, Rich Besser, has been incredibly impressive in standing up and saying, we, the Robert Wood Johnson Foundation, will not be deterred from our mission of trying to address racism in all its forms as it pertains to health, and we're going to continue to do what we're doing, despite the threats coming from Washington. RWJ is not the only one. There are others that are also signaling their intent to continue to fund the work that we know is essential, even though there are folks who are ideologically opposed. So I think it's critically important that funders come in and fill that breach, but we also have to call on our research institutions to also step up. Some of these institutions, I know this is not true everywhere, but some of them have enormous endowments. This is that rainy day. This is when those endowments were meant to be tapped to allow our scholars to continue to do their work. So I'm calling on the field to find creative ways, some subversive ways to continue this work, because we've built so much momentum. We can't stop now. And this knowledge that we've created will not be suppressed. So I'm so grateful for the Robert Wood Johnson Foundations of the world and others that are doing the right thing. I sure hope there are other institutions that are in this fight, such as Harvard, $53 billion endowment. Some of that money could be used to help to continue to support the superb equity research going on at the Harvard School of Public Health. So we've got to find those creative ways to keep that focus upstream and to not allow these political forces to distract us. Thank you for that question.
Thank you so much for your talk. I was just wondering if you have any advice for kind of like beginning researchers, starting researchers in facing this kind of difficulty finding funding and securing funding and not only for research but also for programs and kind of stable income career-wise, right? Especially a lot of the people in this room, I know, and I've talked with a lot of people, it's like, it's not only that, well, we are very passionate about what it is that we do as social justice, but we also have families at home that we need to take care of.
Yes.
We also come from, this insecure, maybe like economically insecure backgrounds, and so stability is a very important thing. And so for me, for example, going into a field where social justice is important, but at the same time looking around and realizing that, well, it doesn't seem like, it doesn't feel like I can have a very financially stable career in pursuing this research. What kind of advice would you give to research?
Yeah, I was worried about exactly this kind of scenario. I'm thinking a lot about those of you who are starting your careers. Maybe you've had research funding yanked out from under you. Maybe the institutional support isn't there. And then there's political pressure now to not study equity, to not study racial justice. The worst thing that I could advise a young investigator is, well, study something that's not so controversial, something that people won't get upset about. You got to follow your passion. And again, we will get through this. 4 years from now, there may be ample funding from a variety of different sources to continue this work because we know it's been working. We know it's been reducing inequities. We know that reducing inequities helps all of us. This is part of that expanding pie, not the stagnant pie. So what can we do? Institutions, again, I think need to step up. Graduate programs that have brought students in, that have had funding yanked out, you got to find a way to replace that funding. You got to continue to find ways to keep people in training. Keep your research chops sharp. Keep reading, keep absorbing information, keep coming to conferences like this. Act as if nothing's going on differently in Washington. This is part of your resistance. But I also recognize that that doesn't put bacon on the table. So we have to figure out ways, including working in the private sector. This notion, the National Academy report that talked about the research infrastructure and that called for private sector investments in a research pool, critically important, because if we realize that that these investors, if their separate interests are supported, then we have no collective. We have no whole that builds synergy and momentum. So we got to find other funding sources and other creative ways to do the work. But I want to encourage you to not feel like you've got to shift into some other field of study to do something that compromises your values and your interests, because there will be a way to continue with the work. But we got to have our institutions stepping up like never before, because we've never faced a crisis like this in terms of at least the federal research support. So I'm confident that institutions will do that. You look at the return on what this research is yielding. Not only are we creating healthier populations, but we're creating jobs, we're building knowledge, and we're helping to lift up the power of the communities that we're working with. All of this is too important to allow the political winds in Washington to decide what we do. Any other questions? I'm mindful that Heather has some words to say.
Any last questions for Brian?
Well, I'll be around after the talk if folks want to talk privately or separately. Again, thank you so much for the work that you're doing. Thank you for your commitments. And let's see each other again in a couple of years and know that we've made a difference and that we're going to get through this and allow our work to continue to flourish. Thank you.
I can't think of a better way to end our time together than with Brian's powerful words. I feel a lot more hopeful now than I felt 2.5 days ago, and that really is because of all of you and because of SPSSI. So I want to thank everyone for that. This time together in community, it's always important. This time has always meant the world to me, but especially now. This is a difficult time, and there is strength in community. I want to thank everyone, all of you, for all that you did to make this such a special conference. I think the breadth and the depth and the thoughtfulness of the work presented was incredible. And I said this yesterday, and I really mean it. The scope of work that we do, the different methodologies, the approaches, but that shared synergy around social justice and change, that is our special power. And in the end, I really do believe that is how we will flood the zone and turn the tide on what we are experiencing during this time. I want to take this moment to, of course, thank SPSSI's incredible staff. Whenever things look easy, if things are going smoothly, it's because so much behind the scenes work. Every day, these amazing people, Anila and Sam and Justin, they blow me away. And they blow me away with their grace under pressure, their kindness, their generosity of spirit, their wisdom, and their commitment to SPSSI and its mission. So we'll hold and we'll have a big round of applause at the end, but a giant thank you to them and for all they do. Also, a giant thank you to our incredible conference co-chairs who are